I am Councillor Lucy Knight, Chair of the committee, and I will be chairing tonight's meeting. The event will be streamed live on YouTube, and members of the public and the media are welcome to watch the meeting remotely and listen to the discussions taking place. I would like to welcome you all to Committee Room 1 at Kensington Town Hall today, and everyone watching on YouTube. Before we proceed with the meeting, I would ask anyone present to make sure that their mobile phones are on silent or switched off, and we will start with 72 seconds silence to remember those who lost their lives in the Grenfell tragedy. Starting with apologies for absence, I've received apologies from Councillor Stephanie Petite, and I think that's the only absence today. And then moving on to the minutes of the meeting held on the 18th of November and the 2nd of December 2024.
Sorry, Chair, declaration.
Does any member have any interest to declare? Yeah. Minutes of the meeting held on the 18th of November and the 2nd of December 2024. The minutes of the meeting held on the 18th of November and 2nd of December 2024 have been submitted for confirmation. Does the committee agree for them to be signed as a called?
I will. We had a really absence.
Yes.
Thank you very much.
And then moving on to hospital discharge and agenda item 4. This report provides an overview of the hospital discharge process in the borough and wider North West London region, including details of the different discharge pathways. We're pleased to welcome Charlotte Williams from Health Watch joining us and from Health Watch and the patient views on this important topic. Also attending to present the report and answer the committee's question is Tanisha Scallon, Assistant Director based Central London, North West London ICF, David Bellew, Borough Director of Health Partnerships and Mental Health, and Councillor Josh Randall, lead member for Adult Social Care and Public Health. And don't know who wants to introduce.
I can introduce. Thank you. Thank you again, committee, for inviting us along. I've obviously got my colleagues here at the more subject matter experts. But yeah, I'd like to present our discharge paper today. And as you know, we've seen from the report, there are 4 elements of discharge. Most people don't need a discharge when they exit hospital. But those that who do will fall under the purview of some of our services that we provide on that discharge. And that can vary. Some people only need minimal help up to kind of quite care and support, especially if they've got dementia or other forms of mental illness, physical illness they will need. What we do at RPKC, which really different from some other areas, is that we have our own officers, support staff based in hospital, especially Chelsea and Westminster. And they've got their whole office there. I've gone to visit them. And what they do is that they assess patients, obviously, that are coming out into the care of council services if needs be, in order to get them home or in a place where they can get them the best possible service. Of course, there are still challenges because sometimes people are a bit faced with going or in terms of staffing or what the care assessment may need be. People can't be discharged from hospital, which is not good for their overall health, also not good for the hospital either, because having people on wards or in discharge areas for a long period of time is not particularly good for anyone. So we try to move them along in the care as much as possible. course, there are sometimes challenges with that. There are individual circumstances that have people that don't wish to be discharged, which is when I visited some of our hospitals, we have people who just don't want to leave the hospital. And of course, how do you deal with that element, which is a particular challenge that some people face. It happens all the time, but it can happen frequently enough. And then you've got people who perhaps are going into need discharge who perhaps don't have anyone at them. So they maybe live by themselves or have family far away. So how can we put them to the best care possible? Because obviously we want preventive measures in place. We don't want people going back into hospital either if they don't need to, where they can get extra support services outside of the hospital care setting, obviously, which social care tries to help achieve. And when you go to Chelsea and Westminster, obviously there's so many people out there, and we often help people trying to go to other boroughs too, because it's not just our borough, they're where that particular hospital has a lot of people from. So our teams work across Wandsworth, Hempstead, Fulham, Westminster, Brent, all those people that may come to Chilvest to do that as well. But yeah, as I said, we're here to take any questions on that and you've used that.
Thank you very much. And thank you for the coming today. I don't know, Tanisha, if you want anything to.
I mean, in fact, we had a good arrangement in place in order to present,
Or David.
to you, but in fact, Councillor Rendell has actually more or less said, most of the things that we were, hoping to cover. So thank you very much for that. I think, what I would just like to add very quickly is that we have in advocacy and also between ourselves and the health, Northwest London and the trust, we have a very good arrangement in place with regards to the discharge processing of residents who are in hospital. And also, we meet on a weekly basis, sometimes, a few times a week. So during the winter months, we step up our meetings, our governance meetings, in order to ensure that we unblock any kind of flow issues, because working together as a system, partners. And I guess I want to say that it works very, very well, within the service. And as just mentioned, effective discharge is really paramount in order to ensure that we don't block hospital beds for others that want to use it, and we work together effectively to deliver that. And one of the points I would like to make is that when people need to discharge from hospital, we ensure that they get the right destination and as quickly as possible. Sometimes people might have to go into a step-down facility like a care home, whether it's residential nursing placement, or they might need to go back into their own home for a period of rehabilitation in order to get back onto their feet. So everything kind of works within that flow. I'll hand over to my colleague to speak about the actual discharge pathways.
So if I take you through just the 4 pathways, just briefly, in terms of how it's actually set up in terms of various different patients that we have and the complexity that we've just heard about. So we've got pathway 0 to 3, so 4 pathways. And pathway 0, our patients who generally doesn't require any additional support. We're saying that there's always almost an 80-20 rule. So you will get the odd patient here that may require some amount of support when they get discharged, but not necessarily healthcare, but it's just more about readjusting back into their home and or anything else that they may need in terms of just kind of daily ongoing support. And we do have people who do that. For example, in RBKC, you got the Red Cross who support Chelsea. So you do have different pathways that we use to build up. So it's not just left going home and just being left. So we do try to support patients as much as possible. In pathway 1, these are patients who are genuinely that are discharged to their home, usually place of residence or into their home, but there may be new health or social care kind of needs. And with these patients who require this mainly rehab or some form of reablement package or support, this is normally done in a collective way through health, social care, volunteer organizations. So again, it's a system-wide approach that we tend to use across to ensure that we are catering for our patients' need. And moving on to pathway 2, which was we call them, our patients who are a little bit more complex, they're discharged to the community bed-based setting but they require dedicated recovery support. So it's a little bit more complex patients. And these patients generally require intensive support. They're general short-term care in residential reablement type setting. But at the same time, they do have a slightly longer assessment and rehab period just to make sure that whatever we're trying to do for them or whatever they want as their outcome, we can help them achieve that outcome. So you can see the various different levels and need of the patients that we tend to use. And lastly, for pathway 3, which are the more complex or most complex patients generally in the system. So their needs are really complex. It's multifaceted, it's multi-agency working. That's what takes up like a lot of our time, even though actually pathway 0, most of our patients fall within that is 80% of our patients. But it does take up a lot of resources for these. And these are the ones that we tend to use what we call like discharge to assess, like a 2-phase approach. And the reason behind that is to ensure that these patients are genuinely getting the right care they need. So by having them step down to a setting, you can do a detailed assessment in terms of what they need. So when they're placed, because they tend to place very, very long time in some cases for the rest of their lives, it is actually the right place and the right need for them. And actually some of the data that's coming out and the things that we're seeing, actually by doing that, we're getting much more improvement. They're not being readmitted, they're not being, so that's the system is working a little bit. I'm saying that we do know we have challenges in our system that we've just heard, and there are lots of, that's what we're trying to do to just continuously improve. So I'm just taking you through that discharge bit. And I'm going to hand over to David just to touch a little bit on the performance of this.
Yeah, sure. So we're quite, passionate in advocacy when it comes to performance because, we're one of the best performing boroughs in Northwest London and one of the best also in London when it comes to how quickly we are able to discharge, people. So our systems, do work. If you look on page 17, you can see the table there that shows the top, darker line. Don't have my same color. And the top line shows the average discharge performance across Northwest London, and and how we kind of benchmark against that. So I mean, there's a spike in December period because of high admission due to flu conditions. We're consistently below the Northwest London average. So we're happy to take any questions.
Okay, thank you very much. Charlotte, I was going to bring you in and then we can move to the Yeah, sure. Thank you. Okay, so last year, Healthwatch Kensington and Chelsea and Healthwatch Westminster carried out a focus project on patient discharge pathways. And I just wanted to kind of briefly outline the findings and to add to the discussion around hospital discharge pathways. So for anyone that doesn't know, Local Healthwatch are a statutory service, and our remit is to act as a local public champion for health and social care, which means that we work to ensure that the public voice is included in the commissioning and provision of health and social care services. And we do that with the goal of improving safety, quality, and accessibility of services. So Healthwatch Kensington and Chelsea and Westminster are commissioned by local authorities, but we operate on an independent and impartial basis. So like I said, last year we worked on a focus project in the area of hospital discharge. And we produced a report in August, and that was patients and carers' experience of step-down care, access and provision in Westminster and Kensington and Chelsea. So before I share those findings, I just want to outline the limitations of the research as well and how that should be interpreted. So the sample size is quite small. We had a total of 15 people contributing to this particular project who were able to provide in-depth information. So we did face-to-face semi-structured interviews with patients and carers. So that gave us some valuable insight into their lived experience.
However, because the sample size is quite small, we can't really generalize that and say that it's the experience of most people. So just to say, it's best interpreted that the local research is valuable information, and it's good insight of patient experience to be added to the existing local knowledge base, but shouldn't be considered representative in itself. So in total, we had 15 participants, and they were recruited based on referral by local organisations, so Carers Network, Age UK, Westminster and Kensington and Chelsea, OpenAge and the British Red Cross as well. And we also encourage participants to share the invitation to participate with anyone that might be interested in sharing their feedback. So the participants included 5 patients, 9 carers who were family members, and there was also a representative from a community organisation as well. The analysis included patients from the SAFE pathway, so 0 to 2. And some were discharged to the community with no new health or social care needs identified. Some were discharged with new health or social needs that would need further support, and some were discharged to a bed-based setting for short-term recovery. So the findings were that in most cases the quality of step-down services was deemed good. However, there were also some issues that participants identified. So these were around poor coordination between services and inconsistencies in communication between and within health and social care services, which could cause issues for patients and carers. The participants also highlighted struggling to navigate the system, and also that information about what care provision they would expect to receive was not clearly communicated. So for some people, it was inaccessible due to the use of language and professional terminology. Some participants spoke of delays to care due to what they felt was ambiguity around who was responsible for providing this. And that was particularly the case when care was being arranged across boroughs. Another concern was that carers reported having to take on an advocacy role in order to better understand and manage their loved ones' care provisions. So those were the main concerns highlighted. And to summarise, the main themes that were identified in the interviews were encountering difficulties during the discharge process, communication around intermediate care packages, the role of patients and carers in the process. So carers kind of stressed the importance of being involved in the care planning process, and that wasn't always the case, which they found to be quite stressful. Home environment assessments and equipment provision had mixed feedback. So some people reported delays and some reported that they were provided with an assessment and equipment that was good. And continuity and quality of care provided was another theme, with patients that received continuity of care reporting that they felt the care received was better quality.
Thanks very much, Charlotte. Chris, questions. I was just going to start by saying, in terms of the report, obviously it comes across as very glowing, and I know that we are one of the best performing boroughs in London and more generally London. But I feel like if you read the Health Watch report and this report, it could have had a lot more substance in terms of understanding, for example, some of the areas that have been raised by Health Watch in August this year, and maybe what we've done to address it, or kind of communications, and I'm sure the committee might ask about that. So therefore, just in terms of those gaps as to mentioning there are delays, but why there are delays, and some more depth of understanding as to have those been resolved, and what I appreciate winter pressures bring delays, but whether if it's to do with step-down beds and equipment installation, or what kind of are your biggest challenges when you're talking about delays, which would give us a bit more kind of information and bigger picture, if that makes sense, just to start off with that.
Yes, thank you, Chair. I think as the performance report shows, by and large, we are doing very well when it comes to discharging people from hospital. However, there are times when we encounter people who have more complex needs, that takes more time in order to find the right provisions in the community. So people that cannot easily go return home. It could be due to the current physical structure of properties, or that they have additional needs that most of our care providers are not immediately able to respond to. So that's a lot of work with providers and also with professional staff to ensure that they have the right service tailored to the person that's leaving hospital. And I can understand that sometimes people want to be able to go into the placement as quickly as possible, but there are some placements that requires a bit more time in order to find them. I mean, the sample that's just been mentioned is a big factor in that. That are only about 15 people with also very few services in that group. But generally, our discharge processes worked well, and also our performance across Northwest boroughs is also good as well.
So to kind of also add to that, to give some tangible things that we've done since improvement, we might have taken some of this role in September with a new change of the organisation. But even since then, collectively as a system, health, social care, have put in additional beds in the system in terms of some of our funding that we have and we've generated. And each week, as we mentioned, in terms of things that we're trying to do in terms of improvement, the feedback we're getting from patients, we're tweaking as we go along. So we kind of have like a continuous improvement process. So that's not going to go in deaf ears, but in some cases it does take time for things to be embedded. In terms of things like, yes, we've increased our bed capacity even since then. We've also, in terms of flu and providing patients that inputs, as you talk about in terms of consistency, we have a hub team that's based in the hospital. They're the main communication with the patient now. So as I said, we're tweaking things as we go along. So most of the communication is coming from the discharge hub. They own that type of thing. So it's a consistent message across the patient. And those are the things that we're doing. So as we come in, we're finding ways of making the process better, but we're not pretending it's anywhere near where we want it to be yet. So that's the bit we just want to flesh out. Sorry, it's not in paper because I think it's just too much, but those are the things that we're trying to do and learn as we go along. And that's kind of what we work across, of course.
I know, just to add that if you look at on page 16, 4.10, we listed some of those improvements that we've made, and partly in response to, that report, there. So, for example, we now have a housing officer embedded with our discharge social work team that picks up any kind of housing issues as quickly as possible, so that people don't, wait long, in hospital. We're also making sure that resident voice feedback are used as part of the discharge, planning, conducting reviews as quickly as possible. So if you look at all of those, key points there, it's also a way where we want to continue to improve, our services.
Okay.
I would say as well, Chair, I think you raised a really good point. I think what Charlotte has raised, the kind of health question was very good. Of course, the report very positive because we try to, as you know, be the best and always aspiring to do that. But also, I think on the basis of what your comments are and what Charlotte's recommendations are as well, that's the benefit of why you're here as a committee to kind of ensure that these processes are brought up to the surface, which may not be get to the right people or having all that kind of stuff as well. So I think the purpose of your committee is to raise those points, and we can obviously take all this away and do that as well, which I think is the benefit, because otherwise we don't want to say.
And I think that's a lot of what will come out today, but I think there's no harm in having read that report, and then this report, it's not criticism when you're sort of improving yourself, but it almost feels more.
Absolutely, no, I agree with you. Yeah.
That we then don't think it's like, oh, well, you only need to read the news
Yes,
to hear that people
exactly.
are putting in beds in corridors. And then, but I appreciate that we obviously we're doing something right to be at it. But yeah, anyway, I'm going to turn to Portia then.
Okay. Thank you, Chair, and thank you for this report. Very interesting. I've got two questions. I just wanted to find out if you've got so with all this experience you've got on the, providing adult and social care to our residents, what feedback are you hearing from the frontline workers? And how can we tap into their information in order to enhance service provisions for our local residents, considering the great job that you guys are doing to try and facilitate and accommodate our local residents' needs? And also, I would like to know, have you got enough care home beds to discharge our residents locally and nearby, Kensington and Chelsea or Westminster?
Yeah, sure. So I'll pick the first one, which is the feedback from frontline, staff. I mean, the feedback from frontline staff is positive. The performance that we are able to demonstrate consistently year on year can only be delivered because of the quality and the experience and the hard work of our frontline staff. I think they really love working in the hospital environment. We are very co-located, as was mentioned earlier. So, and most of our staff are linked in with some of the works in hospitals. So that engagement, that interaction, the multidisciplinary work works very well for our social work teams, and the feedback there is positive. I guess but then obviously during the winter months the admission rates goes up, which means that we have to ensure that we have enough capacity. So that's something that I constantly look at, that we have enough capacity to meet demands of the flow. And like I mentioned earlier, we have regular meetings at the senior level together with the CEO of CharWest, Leslie Watts. We have a weekly meeting to look at making sure that nobody is delayed in hospital, and those people who have complex needs, we work together to try and find a solution on how to move them on. That again reduces the pressure on our frontline staff from having to carry those complexities without any kind of support. So that doesn't happen at all. And the next issue about discharge capacity, the market. We have a director of commissioning, Gareth, is constantly looking at making sure that we work with our providers in our residential homes providers in the community to ensure that we have no capacity for discharge. And some of the grants that we receive from the Better Care Funds enables us to block some bed provisions, so that we are able to move people into those beds that need to step down from hospital environment. But the capacity in advocacy is small. We don't have many homes. There is a long-term plan that we're looking at how to increase, how to expand our capacity, basically with regards to maybe extra care provisions, supported living accommodations, so people don't have to constantly go into care home placements, so we can look after them in the tenancy environment. But there are times when people want to move out of borough because they want to be nearer to their families and who are no longer living in advocacy, and we support them, to do that. And the residents that want to stay in borough, we try our best to make sure that they are accommodated.
Thank you. Just a quick question following up from that. So in terms of equipment, are there any delays in equipment delivery? Do we have enough equipment to facilitate the needs for our residents?
Yeah, sure. So initially, when the NRS contract was adopted, there were some kind of pressure due to the supply side of the equipment, but that has now been resolved, and there is now a good system in place for escalations, because there are times when people need specials equipment that has to be created for them. But in terms of the general equipment, provisions, the flow now works, very well with a very good kind of escalation process in place.
Thank you.
Thank you, Madam Chair. Just if you could really expand slightly on some what you commented on the graph that we're looking at, namely the areas of volatility. It's interesting, it's sort of unfortunate that it starts where it does, because it seems to go from a very low number, jump up. And I wonder, was that first week in October 23, an outlier, or was the period before that a lot lower, and then from the end of 23 it's gone up? It'd be just good to get a comment on that. And secondly, at the very end of the graph, obviously you mentioned winter pressures, but I note that the rest of northwest London's delays in that month came down, whereas ours is quite an alarming increase, much larger than the increase in winter 23. And so I wonder if you could talk to us a bit more about why that happened, other than the general winter pressures that presumably affected the rest of northwest London. Thank you.
So in terms of the graph from October, and that's kind of like the spike you've seen. The first thing I'm just going to say, bear in mind that at the moment our system is experiencing kind of wind pressures all year round now. So you will have variation. This is just because it's just starting from October, but generally, if you look on it, it's pretty much a fairly flat line, slight reduction. So if you look at trend, and I know there's a spike, but I'm not trying to take it in isolation, because when you look at the trend, just because of patient flow and/or. So yes, that could be a reason, but when you look at it, it's a fairly flattish trend. So I'm going to leave that loosely. The spike, I can't quite explain what it is yet because I don't have the data. But generally, when we have any form of slight increase and/or, it's normally born out of things like, I'm going to use that loosely, winter, because that's when winter is kicking in, people are getting ill, we're putting in winter pressures, different resources in, etc. But like everything else, with the best will in the world and the biggest capacity in the world, we're still going to have a little bit of up and down during the winter period. As for this winter, if you go to that increase, again, even the hospitals were drowning all over the country. It's just a sheer volume of people that are in the system that need some form of support. That's nothing we're going to hide away from. That's something we have to keep doing. And as David mentioned, every year we do have a system-wide winter plan between, the Borough, as in Westminster, RBKC. There is maybe the only borough that still continue to do a system plan to ensure that we are on the front foot, we're moving patients through the system. But in some cases, I don't know if I'm necessarily answering the question, but I'm being honest, but in some cases, the sheer volume, we cannot control.
Yes.
And that's the end of it, that if you look at the graph, they virtually mirror one another throughout. But suddenly at the end, which was the point that, is there any knowledge why that doesn't follow the pattern and there's suddenly a spike in one and decrease in the other? That would be really interesting. Maybe it's too soon to know that yet.
Just to add to Jared's point there too, I think it'd be good for us to be able to understand the sort of the different pathways as to where if they've been clumped into one here, but I don't know whether that's a graph you have.
But the data, I'm not going to comment on that specifically because Tanisha and David are the experts. But what I will say is that this winter, December 24, now January 25, is the first year in decades the government has not decided to fund winter health pressures. Obviously, it gives much more money to the NHS over the winter periods, as we know, but this year it didn't. So make that what you will.
Yeah, I understand that. That still doesn't explain the difference in the two.
Yes.
Yeah.
So I think obviously we've given you the data as phase, but we haven't done. There's still sometimes calibration that goes in. Yeah, because this is that kind of cutoff period, and so it shows a little bit of vulnerability. But in fact, we still need to do a bit more collaboration. And so it's best to wait, for a period of time for us to go back onto some of these, records. Because there are times when we have some cases for discharge, sometimes the coding for some of our residents might be wrong or the patients might be wrong, and through collaboration, allows us to be able to kind of, adjust, the back data. So there's still some element of collaboration needs to go through here.
Can I jump in there? Sorry, I'm just looking at the data in a little more detail. The 10th of December, 26th of November, 10th of December, again, winter vary, where it comes extremely early and whatnot. There is a similar pattern, a little bit higher in December, and you see tapering back off. So I guess what I'm trying to say is that if you look at the trend that is happening, we always have a little bit of spike, it's winter, but it taper back off. But I'm just looking even just at the line, the basic line. Yes, we've gone a little bit above the line, but there was still a spike at that period of time.
Sorry, if I may, Madam Chair.
Yeah.
We're missing the point. I mean, if we can look at, sorry, if we look at the graph that we are in the report, the key thing that I think both Councillor Hargreaves and I are interested in is our line goes up and the average goes down. So winter happened everywhere.
Yes.
And as you say, across the country. So what we want to understand is, and I appreciate that these things might change around a bit as you get more data, but overall, I mean, that is a big jump in comparison. So why is it that? So what is it that the rest of North West London were doing differently? If there's anything we can, if we don't know because it's too early, that's fine. But it just is, as Councillor Hargreaves said, all the way along it sort of mirrors each other. And then here we go up a lot, and everybody else comes down.
So yeah, absolutely. I think just to try and reinforce what I said earlier, I think the collaboration needs to be done for us to get a clear idea of what's happening in December, and that kind of analysis, needs to be carried out. And also, if you look at the North West London average, if I could say that Westminster is also high performing as well. Quite often, Highgate is ahead of Westminster when it comes to discharge. We know we're a bilateral service, and we manage our discharge across North West London very well. And so without Westminster, you probably see the big spikes here in terms of the North West London average. Well, in fact, we and Westminster do kind of meet within the same kind of average when it comes to discharging residents from hospital.
Yeah.
Thank you. Putting aside what happened in December, just based on the data, the most recent data that you do have, for let's say for any of the pathways, pathway 2 or 3 or 4, 1, 2 or 3, let's say, for any of those, from the point at which somebody's deemed ready for discharge to the point that they are discharged, for somebody in pathway 2 or pathway 3, what is the average in terms of bed days that's not needed? Because I maybe that's I'm just not reading the graph correctly, but it's just difficult to make a clear figure average for each of the pathways.
So for pathway 1, this one, sorry, I have to graph here basically. So for pathway 1, the average discharge for pathway 1, and I will give you a kind of comparison to say North West London, but we are hitting all our targets. So just be clear on that. All the targets in pathway 1, we are hitting, we're below that target. So in terms of North West London, the average for North West London is hitting around, so the target for North West London is hitting around 7 to 8 days. In terms of ANC, we're hitting 3-ish to 4 days in that range. So that's where we are for pathway 1. If we go to pathway 2, average delay days for North West London is hovering around between 15 and 20. Sorry, I'm looking at the graph and I'm just doing a straight line, so bear with me a second. Between 15 and 20 days. And then the Borough of Kensington on average is actually around 10 to 12 days.
Okay.
So again, and the target that we have, again, we are within that kind of target. And the target that they tend to set, we have one of the hardest and lowest target to meet just because we're already high performing quite well. So to balance out the system, that's pretty much how the target is set. So we already squeezed in terms of the timeline in Kensington and Chelsea compared to other boroughs also, just to kind of give you that kind of context. I don't know if that's answering the question or that's helping.
No, that's really helpful. And I mean, obviously, if someone turns up and the onus is on NHS partners, I guess, to identify who's going to be a 2 or who's going to need a 2 or a 3 as soon as possible, and kind of get us involved, get you involved, or your teams involved. And I just wanted to hear a little bit about that interface and everything's great, obviously, not saying otherwise, but any issues with that interface that you've identified that could be addressed to minimise those delays, and whether if NHS partners were sat here now, what they would say in terms of what the council or the local authority needs to be doing to support them.
Yeah, sure. So yes, I think so. When it comes to, so we have a multidisciplinary discharge hub, and that is basically the first point of contact when it comes to our social work teams. So they flag, someone that is maybe pathway 1, because pathway 0, people tend to go, which are about 80% of people come into hospital. So we have the the discharge hub that the case then gets discussed with regards to who is the best commissioner that is meant to respond to those needs, and when we do the assessment. With regards to the complexities interface, I think I'm trying to dig here to try and find, because we have a system flow meetings, and this is at the senior level and also at the frontline level. So at the operational level, they also have their regular meetings as well, where they go through case by case to make sure that people are not delayed, in hospital. They don't need to be there. We have the housing workers. So that person ensures that people who have housing issues are able to flow, through that. The only pressure that I can make reference to is the flow, the demand. There are more and more people, especially in this current time. There are more and more people that require hospital care and hospital, admissions, and we have a team that obviously is quite limited in terms of capacity, and so they have to keep working as hard as possible to meet those high level of demands. But the main priority for the hospital discharge process is to ensure that people go home. That is always the first focus, in order to reduce the pressure on our community services like care home placements.
I'm just trying to identify if there were areas for improvement from our side, what they would be.
Because funding is always an area. Sorry, funding is always an area. I'm going to put that on the card in terms of the funding that a system has to look after patients as a community. I think that's well known. So with the budget,
sorry, funding for what? Do you mean in terms
funding for placement, funding for additional? Because every budget, whether it's health, whether it's local authority, everybody's peaking their budget and everybody's going at the top of their funding resources that we have.
Sure.
And all the efficiencies we're trying to do is just trying to make sure we improve that and keep that flow. So in terms of one issues, because I think that's what you're trying to tease, or what are some of the battles or what some of the things that we face every day. Funding is a genuine issue. We may not be able to solve it here but that's why we have these kind of meetings, these improvement meetings. And so as we go along, we have loads of MDTs to try and see what's the best place, who's the best place, all of that type of stuff. We're not trying to, we're quite happy to go back and go through all the issues and bring something here, because I think that's maybe some of the bit that you're trying to tease out, or what are some of the tangible issues that we're working through.
Yeah, just because these systems aren't perfect, there are always delays, and 12-day delays. It's that is a substantial amount of time where someone could get a hospital-acquired infection or somebody's outside waiting for that bed. So if in a perfect system from our side, obviously I'm sure NHS services have lots to be doing as well, but where are the issues from our side that could be addressed that would bring that 12 days down?
I think, going back again, I think, if you have enough capacity, as the issue about funding is important, it's really, really cool, because if the funding is across the whole system. So for example, within our provider markets, we are seeing a high need for complex care. So people coming out of hospitals, additional much higher additional needs than previously. So, for example, the need for one-to-one care has grown, and care homes can only admit X amount of one-to-one, patients at any one time. And then they start. So that kind of has a bit more pressure. So, whereby perhaps maybe some few years ago, you probably look at placing people in a very kind of small little area. We're having to kind of maybe look wider, because again of the fact that people are coming across more complex needs that requires that kind of real specialist care. Is one of those issues where definitely that would help.
Just in relation to that, since you've mentioned it, there was talk about an increase in the number of people who need Pathway 1, and what resourcing is being added or is needed to kind of match that extra demand. What were your thoughts on that?
I think the Better Care Fund is actually helping try and manage some of those kind of care needs for Pathway 1s. So that and also we have a high performing and I'm trying to be quite objective here. We have a high performing enablement service, and with a very good rate of discharging people from long-term care needs. So having a robust enablement service for Pathway 1s enables that people get the right rehabilitation as they are in their own homes. To reduce the need for long-term care in the future.
Can I ask one more question about the health watch report, really quick on this? So obviously it's just the 17. It was a small 15 cohort, but there was a lot of really good information from that around difficulties that people encountered about the lack of continuity of care. Some stuff around discharge processes and them being quite rushed, which I think needs to be fed back to CNWL services, the mental health services in particular. But yeah, thinking about the stuff that relates to us, continuity, so having sort of the same people involved in coming in terms of carers, and working around ensuring that the discharge planning happens more collaboratively between carers and patients' carers and social care. There was a list of recommendations which I think need to go. Whether there was anything from those recommendations that you felt that you agreed with and felt did need to be implemented, and what they would be, what you could commit to implementing. Or
I did make reference earlier on. The report is now many months old. We've had series of meetings with HealthWatch to look at some of the recommendations from that report, and that meeting took place together with the ICB, the Northwest London ICB colleagues, and also some of the trusts, staff as well, to look at how do we improve the experiences where some of those areas have been flagged. And again, it's a very small sample, but nevertheless, we're engaged in looking at how we can improve it. And some of those issues, as I mentioned here, for example, having that kind of housing, link worker has really helped to make sure that when people are in hospital and they need their tenancy to be secure, that there's somebody in there that can support them to do that. And also the voices, making sure that the voices of patients and their families are heard during the assessment and the support planning process, and also when they're in hospital as well, that they are able to be engaged in positively. That is one area where there's been improvement.
So the information that's come through from the HealthWatch, the conversation that has started, and maybe that's alluded to it, in terms of the borough, that's what we're taking to plan for next year and to use that in our planning. So we started the conversation. Some of the stuff have already been kind of implemented and half implemented, and the funding that we'll get next year in terms of our grant, that's a part of the plan. So once we get all of that and we've done the plan for next year in terms of any improvement we're trying to make, then we will be, because that's the whole point, we're incorporating what the feedback we get, whether it's from staff, from patients. That's the point of the planning meetings that we're already having now, just to see how we can improve. So they're not falling on deaf ears. I can't give you a full plan in terms of what we've done with every single one of them yet, but we have started that
I
conversation.
think going forwards, it'd be great to see this paper and that sort of combined together to how we can really see that effect. But it would be much more meaningful and getting into because I know we have to leave that.
Well, thank you. Most of the points on to us have been covered. I guess going back to your point about the funding and the delays, and obviously as the pathways, as you go from 0 to 1 to 2 to 3, it feels like the delays get longer, right? So delays at pathway 3 are the longest. So I guess to summarise, what are the key reasons for the delays? Is it because you can't match up the carers and you can't, the complex care package isn't kind of readily available? Is that the main reason for the delay?
Yeah, absolutely. The level of complexity is high for pathway 3s. And by and large, we do get residential care homes that are able to meet those people coming out of pathway 3s in terms of their complex needs. But there are times when it becomes quite challenging not to find the right providers at the right time. And that kind of can lead to a little bit more delays. And sometimes, families tend to also cause the delays as well, because there are times when they want, the person to, they don't agree with the discharge planning process, and they feel that their loved one should stay in hospital for longer.
I suppose if they go into a care home, then that's quite a big family decision and change.
Absolutely. So sometimes, there's a lot of, combining factors that can lead to slightly more longer delays for people on pathway routes.
And then my other question was about the pathway 1 people. So these are people that probably didn't need anything before, but now they do need something when they need some sort of care. What's the process of sort of assessing them financially, for a better description? And is there any delay in that? Because if somebody needs something new, how do we know if they get federal benefits or whether they should be paying for it or contributing to it? Like, how does that work?
So, by and large, people receiving a home care package under pathway 1 to return back to the hospital, they get the first 6 weeks free. They don't actually pay because they go into the enablement pathway, and we don't charge any contributions for any residents going through the enablement service.
So it means if those people are going up in number, the bill's going up because we're covering it.
Yes.
And then after 6 weeks.
Yeah, what happens?
So after 6 weeks, if somebody requires, about 90% of people who come to the pathway 1 enablement do not require long-term packages. So that is why we're doing quite well when it comes to the enablement pathways. But if somebody requires long-term care, then they will be financially assessed to find out how much they can contribute towards that package.
But I guess, sorry, just to finish my point, the financial assessment is not causing a delay because it's happening a long time after the. Okay, thank you.
Jared.
You mentioned about the hub that we've got in Chel West, and what about our residents who go to hospitals outside of Chelsea and Westminster? Is that replicated? Are they getting the same assistance?
Yeah, so they get the same assistance. Obviously, our social work team is based in Chel West, but they also work across Northwest London hospitals, whether it's St. Thomas's hospitals, Hammersmith and Fulham, for example. So anywhere that our residents go to are taken to, our social work hospital discharge team follow them as well. And they work with the discharge hubs across the various hospitals to ensure that we facilitate that discharge as quickly as possible.
Just want to make sure our residents who are going out of Borough get the same excellent service the ones in Borough get from you.
Yes, I can assure you that they do.
Good.
I'm just going to ask a couple of questions, and I know Mary's also got a question. I'll choose if anyone else does. One area, and I don't necessarily know if you're going to be able to answer it, but I know came after the more recent Health Watch report that I read today about winter pressures, was just what I was asked before on it, is just to do with premature discharges, which obviously because of the pressure that hospitals are facing and the sort of concern that people are being rushed through the system. How do we monitor that as a council, as NHS, and know that people's health isn't being put at risk because of the pressure we are feeling. And I don't know, maybe you have updates in your meetings each week, but that was one concern I had. And then also just we've spoken about communication a bit, but sort of what measures are in place. You've spoken about the housing officer and obviously the Red Cross for working, but from the work from Health Watch's report last August, the measures that are now in place to help improve communication and ensure patients fully understand their immediate care plans or their medication, or just that kind of barrier of language that sometimes can be quite overwhelming when if someone has a carer who's supporting them, but also if they're okay.
Can I take the commentary one and then you can take the other one? Is that okay?
Sure.
So in terms of premature discharge or not, patients are only discharged when they're medically optimized, i.e. they do not need to be in that setting. That's the time when that clock starts. If something has happened to the patient when they get discharged or whatever it is, that's a slightly different conversation, but rest assured that from a medical perspective, that's when we start talking about delayed discharge or all of those kind of conversations, only when the patient is medically fit to leave that setting, which means that whatever that they require in the hospital, in a nutshell, they don't require that type of support anymore. Hence, that's why all of these pathways for them. So I'm not quite sure how I answer that question, if that makes sense.
It's only because it came up in their most.
But that's fine. There's also another metrics where we're looking into in terms of how patient or people are going back into hospital. Are there anything else? So from a system perspective, we may look at if somebody's coming discharge and I don't know, 1 day later, 2 days later, they're back in A&E or something like that. That's something with a flag up on our radar.
Yeah.
We're not seeing that at the moment.
Yeah.
But that would be something that would flag up because somebody else would have recognized that name, and those names are not coming up on a regular basis.
Yeah.
But I just want to just make that point clear despite the.
Thank you.
I mean, just to cover the communication, as in the question, I think, we do have, so our assessment process ensures that if anyone needs to be discharged from hospital, that their voice is heard, so their voice is captured in our assessment process. Now, if people lack capacity or there's any kind of language barrier, definitely we get a translator to assist in that process. If they lack capacity, we go through a mental capacity assessment and develop a best interest. That process has embedded representative in that, so we cannot progress to a best interest without having either a paid rep or one of their next of kin to assist in that best interest decision.
And that's a rep who's attached to the local authority or
So that is the MCAR. That is a separate independent organization that is funded by the local authority. So we pay for an MCAR as is required by law for us to do so. And they come here to represent the person. That is if the person is not befriended. So if there is somebody there to represent them. So our assessment process captures that. There is an ongoing, as part of our system leads discussions, there is an ongoing conversation about making sure that people have, their voices are heard when in hospital around the pathways. And that's something that we continue to make sure that is kind of reinforced as we go forward.
Okay, thank you. Mary.
I wanted to ask two questions. The first is about I really didn't get the graph, but I think it means there are 2 snapshots a month showing on that day how many patients were in hospital on that day who should have been discharged. Is that correct? Is that what that graph is saying?
Yes, so it provides, the flow average.
It's an odd way to present the data, I think. It's just a very eccentric, it's not very helpful. It would be better to have a whole month and the number of days per month, but snapshots are just, and that kind of graph. And out of how many patients, that's the other thing there's no context in that graph. Are there 500 patients in hospital of whom 30 should have been discharged, or 35 of whom 30 should have been discharged?
Yeah.
I think that context would be very helpful. And the other one thing I wanted is, should there be, this is a good measurement, should there also be a measurement of how many people are discharged but then go back into hospital for the same malady because they haven't been looked after properly? You might have discharged them, got them out of hospital, but not got them looked after. And I say that because I've got experience recently of somebody who get discharged from hospital, very poor care from the district nurse, the same infection came straight back, cellulitis, back into hospital, readmission. And that readmission is as much a failure as a failure to get her out of hospital in a timely fashion. And I wondered if we've measured that and if that ought to be part of this kind of report.
Yeah, I completely agree with that.
So that's what I alluded to earlier. So we're now starting to pull that data through to add to our discharge pack that we produce on a regular basis. So generally on a monthly basis, we produce a discharge pack. The currency to measure this is actually discharge. Yeah, we've also added, so we got a lot more richer data. We just put one data in here, so apologies. But what we are adding and we're building, because what we want to see is understand the full system eventually. So all the data we've done across both Bible, I think maybe have maybe one of the most richest data, hence that's why our performance can keep improving. But we have a lot of the data, but we're just making sure that it's the right information we put in.
I mean,
so that's
it's not
the next
hard
thing
to measure, I accept that.
No, we can measure it. We can measure that. That's one thing we can measure. What we're not trying to do, just making sure the data is accurate. And so, because if we're pulling from various different systems, bear in mind that getting our data, it's not just one system. We have social care data, so that's what we're working on now, just to make sure possibly next month or so we can then start putting that together. But we do have that data that we can measure. We just have to make sure go through some quality assurance, if that makes sense. So that's the next layer that we add into it.
Yeah, I think that's
Yeah, just to comment about premature discharge. For example, our social work team will not get involved in any kind of discharge process when the person is not ready. If the person is not ready, I mean, that is, we just don't do that. And we have a good relationship with our trust that they also respect us as well. So when we say this person is unwell, they kind of they don't kind of dismiss our concerns. Whereas someone discharged as part of the family kind of decision or maybe a self decision to leave hospital, obviously, that needs to be looked into in terms of how the discharge could be kind of prevented in future. But when it comes to how we work and how we operate, we don't get involved in any premature discharge.
Yes, correct.
You wouldn't necessarily get involved until somebody has said this patient is fit and ready to go home, and I think that does make sense. But that doesn't necessarily mean that once the patient is out, the quality of care that they're getting in the community doesn't impact on the question of a failed discharge. And I guess that is useful information to have. Failed discharges that have failed, not because somebody says that this patient's ready for discharge when they're not, but also the quality or the availability of the care that they are left to in the community isn't sufficient enough to keep them out. And I think that would be worth knowing about.
Absolutely.
And should be quite easy to get as well, data on failed discharges.
Failed discharges is linked to the hospital admission, as we're talking about. And then normally what we tend to do, if you see any of that's flagging up, is the kind of meeting that we have in place to go through kind of like the why, where are the issues, and then that's generally how you tackle it. But yes, that will give you an idea once we start getting the hospital like readmission, we call it hospital readmission, that will start giving you an idea of what failed discharge or what that looks like.
I mean, just to add on to that is whenever we organize care for someone that is discharged, we continue to follow up as well. And not only that, where we've been involved in somebody's discharge, even if there is no support in place, because there are times when people say they don't want any care, and we might offer it, people might also reject the care. We follow up as well. So the social worker will make regular phone calls just to ensure that person is well, in their homes. So there is kind of ongoing follow-ups. And if we find that somebody's health as deteriorated. Of course, we discuss it with their GPs and organize a readmission if that is required. But there's constantly follow up for those people who do not receive any care, but we believe that they need that kind of monitoring following their discharge, and also those people who have regular care. We follow up as well to conduct a review post discharge.
So bear in mind that we do have other community, because I know we're focusing on just the discharge and discharge scheme, but we do have a lot of community support. But there's GP, but there's the community team as you just mentioned, and they do knock on their doors. They do go in and do welfare checks at times. I'm not going to pretend I'm going to catch everybody in the system, and all we're trying to do is build on it. But there are other organizations that support us. The voluntary organization are very, very important in all of this, whether it's before they get into the hospital, after they leave the hospital, because they know they're more in those communities. So we do tap into those resources. I know we're trying to juggle the whole system, but we do tap into all of that. So it is literally a collective effort. But we do know things happen, things do go wrong. That's not what I'm not trying to say that, but we're generally trying to hold this together and improve as a keep going.
Very
Really quickly, it's more about how the data's presented. Obviously, having a number of unnecessary bed days is one useful metric, but also with useful is like Mary was saying, just about the patient number. So on average, each month, how many patients there are on a detox on a delayed discharge list. So rather than it being just about the number of days, I mean, just having a snapshot each month and to track that, how many patients there are per 100, say, that are literally on a delayed transfer of care list or a delayed discharge list. Because the outcome was really difficult to understand.
Rescue David, that graph was not got down hugely well in terms of being useful to understand.
I think also I know Roberta wants to ask a question, but in terms of the graph and what might be really helpful to us, just generally as a committee, is firstly seeing where the data goes after the big spike, just so that we can kind of understand your learnings, because I think that's obviously one clear concern that's come out today is the different ways that's going, but also the breakdown in terms of pathways, so that rather than it being clumped into one, whether we can see where delays are happening and maybe for it to be formed in a different way, as Mary said. And yeah, I think it'd be really useful for us to be able to. I don't know how often do you kind of produce that graph. It might be something kind of quarterly that is a useful thing to kind of come to if possible. If that's something you're doing anyway, just so we can kind of keep an eye on it in comparison to the North West London.
Should I record that as action?
Yes, please.
And also, if I could go back further, I think the idea that you need to get 2 full years would be.
Go back further too would be no.
I'm gonna pause, but I will look into that because the data we've come together as a system, trying to pull loads of systems together, and we may not necessarily. I'm just saying that could be where we kind of start getting the meaningful data.
Yeah.
But if we can, I'm just going to make sure you're aware. We will go back and we can go back over 2-year rolling period or whatever the system, so you can see. But I just want to just be cautious because literally just get this in one place where we can make meaningful conversation from it.
And I think Mary just mentioned too, but I think generally this paper kind of coming to us readmission data as well is a really interesting way to know that the service we're providing is working. I know that you just said you've only just started collecting that, but
just to arrange my actual question, sorry, Madam Chairman, was on the point that Councillor Wheel raised, where somebody goes out and then comes back in terms of from a funding perspective, does that 6 weeks, would that 6 weeks that we cover, would that be reset so that when they're then discharged the second time, we're paying for the 6 weeks again?
Yeah, absolutely.
Right, okay.
So that's done.
and yeah, just anyone else got any other questions? More generally, I think I've said it already, but just to kind of the report that I helped with gives me some idea. I don't know how long I see it, but going forwards that this can be and we know that if there's bad things get paid, but it's still performing well above average, and it's kind of great for us to see where things are being amended or going right when things being flagged. So doesn't need to be sort of pristinely flowing the whole time. So always raises more questions when you read the news. But yeah, thank you all so much. Charlotte, I don't know if you want to say anything. You don't have to, just in case you want.
No, I just had a query on the data. When you do the analysis, are you doing it? Are you looking at demographics as well in that?
Yeah, I mean, this data is just a snapshot. I mean, we can go deeper into individuals as well. So we do have all of those kind of, underlying data sets that is, required.
Brilliant. I was just thinking about inequity there. It would be good to kind of build a picture on that.
Thank you all so much.
Thank you, much.
Moving on to our work programme reports. This report sets out development of the Secretary's work programme identifying priorities for the municipal year 2024-2025. Does the committee agree the work programme for 2024-2025 sets out in appendix 1? Yes. And we've already discussed the okay. If you got that. Let's do the presentation. Yeah. How's the option? And we're going to try and do a visit also for the
yeah, that's right, Chair. So we had to move the paper we had papers we had to screen it tonight back to April. That's to allow the NHS to produce the report, and also to allow Dr. Jo Ruende to attend as well. So she's going to come to the meeting in person. And as Councillor Knight mentioned, we're also going to do a final visit to the cancer charities, which does support patients and advanced as well, just to give you another perspective of the services.
Yes. And I was also going to say, Mary, in our last OSC, we were talking about the visits that we should start doing, which are more to kind of care homes. Do you want to just explain a bit about that? Because actually, I don't know.
Explain the concept of doing the visits.
No, we've obviously been visiting services that how it obviously operated before I was on this committee, that we were doing much more regularly, even if it was 1 or 2 people.
Yes, so we had at the beginning of the year, the committee clerk or sport would produce a list of places to be visited and allocate them to people.
Yeah.
So for example, somewhere like Burgess Fields or and then as a regular part of the agenda, people would have a pro forma to fill in, and then when they'd done their visit, they'd submit it to the committee clerk, who'd then attach it as part of the agenda, and it would just, under any other business, if there were any issues raised.
Yeah.
So, for example, I can remember going around Burgess Fields and saying the carpet in the common area is disgusting and it needs replacing. I mean, as simple as that.
Yeah.
But also other things about whether it was understaffed or great or wonderful, staffing, marvellous, that kind of thing.
I was thinking around that.
Yeah, I'm sure we can try
At that. That was like good.
The July meeting is quite chocker, isn't it?
July is.
Got 3 major items. Is it going to be 3 major items of meeting? Is that what?
Well, July would be starting. So yeah, so that's
Yeah.
that's the plan campus.
Yeah, okay.
Obviously, the other important change to the work programme is I said at the last meeting to that we hope to have the NHS here to discuss palliative care and the conversation around that. So to be clear, what's happened since then is, and we published a letter, the NHS have confirmed that there's now considered to be a statutory configuration of all 8 London boroughs. That means we'll have to work with the other affected boroughs to form a joint committee to review those proposals. We did have them here in October 2023, but we won't be able to do that. We'll have to join in with the other boroughs.
What does that, do we know that what that means to when the decision or the consultation is about to end?
They haven't said when they're going to make a decision.
Okay.
They should go on for the
And some of this presumably is driven around when reports are published or when throughout the course of the year.
Do you mean the general?
Yes,
Yeah. As in when we choose things on the work programme that you were just speaking about.
Yeah, so there's a health watch report that goes in that time of year. There's a safeguarding report that goes in that time of year.
Yeah. In terms of that, the work programme, yeah. And then I think that in what you're saying about the Pembridge is we won't know when that.
The NHS haven't said when they're going to make the decision at that board about the options which they published around the Pembridge and around community services or palliative care. They have said that they're going to have statutory consultation, which is underway at the moment, but they haven't said, and I have asked them when exactly the decision will be made.
So that's just to update on that.
Public meeting next Wednesday as well.
The meeting. Is there anything else anyone else wants to add today? And then we've got our first meeting for suicide prevention in March.
3rd of March.
3rd of March. Right. That concludes this meeting of the committee. Thank you everyone for attending and the chair.
I'm sure vision, I wasn't going to do any supper, but maybe I'll try to look to the agenda.
Yes. Now the wind's behind you.
Do you want to sign any minutes?
Yes, please.